Okay, thank you for the invitation. I'm excited to give this talk to you. It's actually an update from a talk that I gave at EULAR on, last month on the safety of Jakinibs, as there's some new information. So here's my conflict of interest. And let me start by saying that if a medication isn't safe, efficacy really isn't important. So efficacy really depends upon safety. And that's what the regulatory authorities around the world think about in terms of approving drugs. How safe are they compared to their efficacy? What's the risk-benefit ratio? So I don't need to remind you all that rheumatoid arthritis is a multi-system disease with multiple comorbidities, as seen on this slide. There are comorbidities that occur much more frequently in patients with rheumatoid arthritis than the general population. And included in that is cardiovascular disease. When I was in training in the last century, I was taught that patients with rheumatoid arthritis have a decreased life expectancy of somewhere between 8 and 15 years, and primarily due to cardiovascular disease. We also know that malignancies, especially lymphoma and lung cancer, are higher in the rheumatoid population than they are in the general population. And we also know that the incidence of VTEs in patients with rheumatoid arthritis, no matter what their therapy or no therapy, is approximately twice what it is in the normal population. So when we talk about JAKs, this is a very complicated slide, but the point I want to make on this is, if you take a look at this, the JAK inhibitors affect multiple signaling pathways. And by affecting multiple signaling pathways, there are multiple abnormalities that can be seen with respect to safety. And that's what we're going to talk about this afternoon, this morning for me. So we've used JAK inhibitors since 2012, when tofacitinib was approved in the United States for the first time. And we now have 3 Jakinibs that are approved, which includes tofacitinib, baricitinib. Baricitinib is only 2 milligrams in the U.S., and upadacitinib, which is 15 milligrams a day. And filgotinib was not approved. The 2 milligram dose of baricitinib was approved, but the 4 milligram was not, because of perceived safety signal with respect to VTEs, which may or may not be true, actually. And with respect to filgotinib, I'll show you the reason why in just a couple of minutes. So what we know is that when patients are on Jakinibs, there are adverse events that we have to look at. Serious infections can occur. They occur about the same proportion as patients on biologics. Herpes zoster can occur, and herpes zoster does occur more frequently in patients on Jakinibs than other medications. And other opportunistic infections can also occur. What's interesting is, in all of the clinical trials, all the databases that have been accumulated for the JAK inhibitors, the standard incidence ratio of malignancy, according to a normal database, which is the SEER database in the U.S., is approximately 1. Now, we know that lymphoma occurs more frequently, we know that lung cancer occurs more frequently, but there are certain cancers, such as colon cancer and breast cancer, which occur less frequently. So when you average all of these, the risk is 1, but there's some that are more frequent, some that are a little bit less frequent. And we also know that the JAKs, whether they're a pan-JAK or JAK1/2 or predominantly JAK1, they still all have some JAK2 effect. And for that reason, you can see occasionally anemia, significant anemia, neutropenia, and lymphopenia in patients. It occurs rarely, but it does occur, and we know about that for years now, almost 10 years. And we also have noted in the clinical trial programs that there is increased liver function test abnormalities associated with the JAKs. And this is generally when the JAKs are used in combination with methotrexate. When the JAKs are used as monotherapy, the elevation of the liver function test is much, much less. And for unknown mechanisms, with every one of the JAKs, see a mild increase in serum creatinine and an occasional increase in CPK, which can be quite high. But in my experience and in my understanding of the databases, and I know the databases of all 4 JAKs, there isn't a single patient who developed renal failure or myositis secondary to taking a JAK. And it is by unknown mechanisms. The JAKs increase lipids. And then I put down, but they may not increase the cardiovascular risk in RA. And that seems, kind of paradoxical. But I've published, it's been published by others as well, that the increase in lipids, as you see with JAK, is due to a decrease in cholesterol esterification, interference with the esterification. So the lipids that are produced, although it's higher, have a normal HDL-LDL ratio, and the lipids are actually larger particles, and they should actually be protective. And that's the reason why I say they may not increase the cardiovascular risk, but we'll see what the data is later in this talk. And then there's the question of GI perforations, because the Jakinibs do affect IL-6, and that the perforations are associated in patients with a history of diverticulitis. It's true diverticulitis, not diverticula, or due to steroids or NSAIDs, as we know from these 2 agents themselves. And then there are venous thrombotic episodes, which I'm going to talk about later as well. Here are special populations and dose adjustments, and this is from the U.S. I do have the asterisk, which is the EMA guidance on this as well. So you can see that with tofacitinib, if the patient has a creatinine clearance of less than 30 milligrams, you reduce the dose to 5 milligrams a day. And for hepatic involvement, for moderate, it's 5 milligrams a day, but in severe, do not use. And that's true for all of the Jakinibs. I should say that with baricitinib, for less than 60 milligrams a day, the guidance is do not use. Upadacitinib has no restrictions because it's not renally excreted. And filgotinib has the caveat of a creatinine clearance of 15 to 60, use 100 milligrams a day, and do not use if less than 15. For elderly, there's no dose adjustment, except in the EMA, they do suggest caution in patients over the age of 65. But it's a use of tofacitinib in patients over 65, not a dose adjustment. And for filgotinib, it's over age 75, use 100 milligrams a day. And pregnancy and lactation, all 4 of them not recommended. And for spermatogenesis, it's not been an issue with tofacitinib, baricitinib, or upadacitinib, but it is for filgotinib. So with filgotinib, impaired spermatogenesis and histopathological effects on male reproductive organs were observed with filgotinib preclinically in experiments in rats and dogs. And for that reason, Gilead and Galapagos did a study, are doing a study actually. It's called the MANTA study. It's in 250 males with IBD, males obviously because of the effect on the testes and epididymis. And they did report their top-line results in a press release. We haven't really seen all the data in March. And what they said was that in the first 3 months, 8.3% of patients on placebo and only 6.7% of patients on filgotinib had a 50% or more decline in sperm concentration at week 13. So that looks good, but that's really not the whole story. The study goes on for a year, and the patient is still being followed. And the question is going to be that over the year, are more patients with filgotinib going to have more difficulty with spermatogenesis and histopathological effects compared to patients on placebo or not? So we have to wait for the results of that. But that's one reason why the FDA did not approve the dose of filgotinib at 200 milligrams a day, and the company didn't want to accept 100 milligrams a day. But I want to spend most of this talk on malignancy, MACE, mortality, and VTE, because that's really been in the news over the past year with various press releases and various pronouncements from the FDA and the EMA. And the question is, are Jakinibs, and specifically tofacitinib, because this study was done with tofacitinib, associated with increased or similar decreased risk in patients with RA? And what's the risk compared to TNF inhibitors? So here's some very important background for you to remember, because this is old news, this is old history. As I stated before, we know that RA patients have an increased risk of cardiovascular events. And it's not just the traditional cardiovascular risk factors, but also because of inflammation. And past epidemiologic studies have shown that DMARDs, and it's primarily methotrexate, have been associated with a reduced risk of cardiovascular events, including methotrexate and TNF inhibitors. So if you take a patient who has rheumatoid arthritis untreated, compared to a patient who's treated with methotrexate or TNF, their risk of cardiovascular events in the treated patients is reduced by at least 50%. There's a reduction of at least 50%. And probably more so with TNF than with methotrexate. And with the reduction in disease activity, that's what's been associated with the fewer cardiovascular events. And compared to conventional synthetics, mortality and cardiovascular events were significantly reduced in patients treated with TNF without increasing the risk of solid cancer in patients with or without prior malignancy, and it's thought that this is again due to reduced chronic inflammation. So TNFs are better than conventional synthetic DMARDs, which are better than nothing at all, in terms of reducing the risk of cardiovascular events. And then on the fifth bullet, comparative effects of TNF, non-TNF biologics, conventional synthetics on cardiovascular risk in RA. And this is compared to TNF inhibitors, tocilizumab may be associated with a reduced risk of MACE, whereas conventional synthetic DMARDs may be associated with an increased risk of MACE. So in this particular study, all the patients had a reduced risk, but it was better with the IL-6 than it was with the TNF, and it was better with the TNF than it was with conventional synthetics. However, as a real study was done, not just looking at databases from registries, which compared tocilizumab to etanercept, to TNF, and they found that the risk of MACE was exactly the same. And I believe that study because that's a well-done prospective head-to-head study. And then real-world evidence studies in RA patients have suggested potential cardiovascular benefits with methotrexate. So let me just summarize this whole slide. Patients with rheumatoid arthritis are at increased risk of MACE, cardiovascular events. Treating them reduces the events, and methotrexate reduces it by about 50%. TNF inhibitors may reduce it more. When we take a look at VTE and PE, as I said before, these are two studies, a combination of two studies that were done early on. This is way before we had TNFs, way before we had JAKs, as a matter of fact, way before JAKs. And the relative risk of a pulmonary embolus or a DVT or PE or DVT was approximately twice that of the normal population of patients with RA. So no matter what drug the patients were on or whether they were on drugs, their risk of VTE is higher than the normal population. And this is an interesting study, which was actually, this slide is taken from an abstract that was presented at EULAR in 2020, but it's been published now. And this is from the Swedish and from a registry, and they looked at the relative risk of a VTE based upon disease activity, and they used a DAS28 CRP category, actually. So if patients were in, quote, remission, DAS28 CRP less than 2.6, which really isn't remission, but if they were that low disease activity, their risk was the lowest. And if their DAS28 CRP was between 2.6 and 3.2, there was some increase in the risk, not much, but there was some. If the DAS28 CRP was greater than 3.2, there was much more risk, it was 1.5 times. And if the patients had a DOS28 CRP greater than 5.1, their risk was 2 times higher. So what this is saying is that the VTs occur, they do occur, but the risk is elevated in patients with more active disease, which follows what we've really observed in populations over the past 20, 30 years. So this is a registry. It's the Corona Registry. It has lots of warts, but it does have some good points, and this is one of the good points. So when tofacitinib was approved in 2012, part of the agreement with the FDA from Pfizer was to do post-market safety surveillance of tofacitinib versus biologics. And they used the U.S. registry, obviously, which is Corona, which is the largest. So you can see the number of patient years in the bottom. Here it's about 3,000 with tofacitinib and about close to 12,000 with biologic DMARDs. And in this registry, the incidence of MACE numerically was a little bit lower with tofacitinib than the biologics. And the confidence intervals overlapped, so the take-home here is that they're probably very similar. With serious infections, numerically a little bit more with JAKs, but again, the confidence intervals overlapped, so probably pretty similar. Herpes zoster was different. Herpes zoster clearly occurs more frequently in patients on biologics. But if you take a look at malignancies or non-melanoma skin cancers or death, there's no difference between the biologics and tofacitinib. So in this registry, it's all patients with RA. And it's all comorbidities, it's all ages, or not many comorbidities, and younger people. It's the whole population. It's not a specific population. So in this whole population, the only thing that was different with the JAKs, which we know, is the increased incidence of herpes zoster. Not MACE, not SIEs, not malignancies, not non-melanoma skin cancer, and not death. And this is important to remember when you're treating patients, because you're actually treating these types of patients. And this again is looking at the same data in different ways, and you can see that the risk of herpes zoster is increased with the JAKs. It is a little bit lower with MACE. In this registry. I've written a number of manuscripts and have given a number of talks in which I've talked about how it's inappropriate to compare one study to another study. If you show me a study of tofacitinib and methotrexate in complete responders, and you compare the clinical outcomes, such as ACR responses, or DOS responses, or CDAR responses, or HAC responses, or even radiographic responses, the tofacitinib to another drug, such as baricitinib, or upadacitinib, or filgotinib, or TNF, it doesn't make any difference. You really can't compare them. Philosophically, it's really very difficult. It's ethically probably unsound. And the reason for that is that these different studies are done by different investigators, different regions of the world, different patients, different points in time, different concomitant medication, different disease activity, etc., etc., etc. And there are too many biases to be able to say that one is better than the other or not. The only way you can tell is by doing a head-to-head. So what I've done here is I've actually done that, but I've done that with safety. And the reason why I've done it with safety is I've used the integrated safety analysis from all of these drugs. So these are the entire clinical program, everybody that they had. So there's still some risk of bias, but there are still really important points here. So if you take a look at herpes zoster with tofacitinib, baricitinib, upadacitinib, the rates are very similar, but they are a little bit lower with filgotinib. They are. SIEs, very similar with tofacitinib, baricitinib, upadacitinib, but a little bit lower with filgotinib. But importantly for this talk, look at malignancies and look at MACE, and they're actually all the same. They're very, very, very similar. So this is going to raise the question as to what I'm going to discuss with tofacitinib as we go forward in this talk actually relates to all the JAKs or not, and we don't know the answer. So this is a study that I've been leading up to, and it's gotten a lot of press in the U.S., and it's got a lot of interest in Europe as well. And it's the oral surveillance study. It's the Pfizer 1133 study. So the background of the study was that during the FDA approval, there was noted an increase of lymphoma when higher doses of tofacitinib were combined with other immunosuppressant in renal transplant program. And so tofacitinib was originally developed for as an immunomodulator for renal transplant. And they were using doses of tofacitinib of 40, 60, 80 milligrams a day in combination with other potent immunosuppressants such as Cytoxan, Imuran, etc. So the FDA was worried about this because this is the first time they had seen this mechanism of action, and they didn't know whether or not the lymphoma would occur with the lower doses of the 5 and 10 milligrams of BID of tofacitinib. And they also noted that there were increased serum lipid levels, as we've noted with all the JAKs, and they've given the reason why they're elevated and actually why they should be safer. But in 2012, the FDA didn't know that. So they wanted to do a study that looked specifically at malignancies, specifically lymphoma, and the effects of increased serum lipid levels. Because it wasn't known whether or not these were a similar rate with biologics, the studies of tofacitinib included 2 small studies looking at a comparison versus biologics, and actually only one of them was done at the time of approval. The FDA required a prospective, what they thought was properly powered, but it turns out it was an underpowered study, head-to-head post-marketing safety study comparing tofacitinib to TNF inhibitors to test for the relative risk of developing MACE, or major cardiovascular events, and malignancies. And the study population was limited to patients who were at increased risk of MACE and malignancies. So this population is very, very different from the population you see in practice, the population that was in Corona, the population that was in all the databases, because every patient had to be at least age 50, nobody younger than 50, and they had to have at least one cardiovascular risk factor. And they were all on methotrexate, and they had to have active RA despite methotrexate. So this is a very specific population, older with a cardiovascular risk. So the objective was to evaluate the safety of tofacitinib, both doses, 5 milligrams BID and 10 milligrams BID, versus a TNF inhibitor. And they used 2 TNF inhibitors. In the United States and Canada, they used adalimumab. And in the rest of the world, they used etanercept. So the reason why they used etanercept in the rest of the world is that Pfizer has etanercept in the rest of the world, but not in the U.S. In the U.S., they went with adalimumab. All the patients were on methotrexate. They had RA. They were at least age 50, and at least one cardiovascular risk factor, as I stated before. And the co-primary endpoints, there were 2 of them, were the non-inferiority of tofacitinib, and this is the combined doses, 5 and 10 milligrams, not either one, compared to TNF inhibitors, and it's the combined TNF inhibitors. We don't know about each one of the TNFs. It was combined in regard to MACE and malignancies, and the way they defined the non-inferiority would be, to me, was a little unusual, but it's very, very, very usual for the FDA and other regulatory authorities actually to do this in safety. They defined it by the upper bound of the confidence interval not being greater than 1.8, and they didn't calculate the lower bound. If it was defined as a non-inferiority where you looked at the upper bound and the lower bound, the results actually would have been different. But they didn't. They did it only by the upper bound being greater than 1.8. And the bottom line results, this is a Pfizer press release, and we haven't seen this data presented. It was submitted to EULAR, and wasn't accepted at EULAR because they already had seen the press release, and they didn't think that there was be anything different in the presentation. There was. I was on that presentation, but they didn't accept it. It's been submitted to the ACR, and the paper is currently being written now. So the top-line results were the pre-specified non-inferior criteria were not met for the primary comparison of the combined tofacitinib doses to TNF. And here are two important points, the two last points. For tofacitinib, the most frequently reported MACE was myocardial infarction. Not surprising, that's what occurs in rheumatoid arthritis. And the most frequently reported malignancy was lung cancer. And that's not surprising. It's very common in rheumatoid arthritis. And then this last point is important, and I'll emphasize it later on. But in those subjects with a higher prevalence of known risk factors for MACE and malignancy, older age, or people who ever smoked, a higher occurrence of events was seen across all treatment groups. Well, you know, when I originally saw the press release, I didn't understand this because clearly patients who are older age and who ever smoked are always at a higher risk for MACE and malignancy. We know that. But it was across all treatment groups. It was across TOFA and the TNFs. So the question in my mind, when I first saw this, before I saw any of the other data, was, well, what about younger patients? Are the risks the same? So here are the results. And if you take a look at the top in yellow, the non-inferior criteria was not met for the primary comparison of combined doses of TNF, since the upper limit of the 95% confidence interval exceeded 1.8. So we go to the hazard ratio. Here you can see the number of subjects, the number of the first events, the person years, a lot of patient years, and we go to the hazard ratio, and you can see with tofa 5 milligrams, the upper bound was 1.91, higher than 1.8, and for 10 milligrams it was 2.18, and for the combination it was 1.94. All of these are higher than 1.8, and therefore it failed. But I want to point out the incident ratio. So the incident rate was 0.91 for tofa 5 milligrams BID, and for the TNF it was 0.73. Both very low, but numerically a little bit higher with tofa. And the way you get the hazard ratio is you divide the 0.91 by the 0.73, and therefore you get the hazard ratio of 1.24. So, but the incident rates are low, and from this you can actually calculate the numbers needed to treat, numbers needed to harm. And the numbers needed to harm is about 450. So you'd have to treat 450 more patients with tofacitinib 5 milligrams BID to get one more MACE than you would with a TNF. The next slide is malignancies. And again here, the non-inferior criteria was not met because the upper bound of the confidence interval here for the tofa was 2.18, 2.19 for tofa 10, combined was 2.09, so it's greater than 1.8, and it failed. But again, look at the incident rate, and the incident rate was 1.13 versus 0.77, both low. The 1.13 we think is very correct because that's actually what's been seen in the long-term safety data from the Corrona Registry with respect to malignancies with tofa 5. The 0.77 may be a little bit low. It's a little bit lower than we see, but be that as it may, in this head-to-head study, a little bit higher with tofa than it was to the TNF, and they did not meet the criteria, so it was a failed study. The non-inferiority was not met, but again, you can calculate the hazard ratio, and the hazard ratio from this is about 250. So you'd have to treat 250 more patients with tofacitinib to get one more malignancy than you would with a TNF. And that, of course, is an important point when you're thinking about a patient. Then this is the PE data, and this had been presented a year ago, and there was a lot of discussion on this. So with respect to pulmonary embolism, the incident rate with tofa 5 was 0.27. It was higher with tofa 10, but it was only 0.09 with TNFs. That's a little bit lower than we would have expected. So if you look at the upadacitinib program, the tofacitinib program, where they compared the JAK to a biologic, or methotrexate, or placebo, the incident rates of VTEs were very, very similar in all of those groups. There wasn't a difference, an increased risk of VTE compared to any of the comparators in those programs. But the hazard ratio, because again, you divide 0.27 by 0.09, and it comes out to 3. But the incident rate is low. I will tell you that this is not statistically significant, TOFA 5 versus TNF for PE. Deep vein thrombosis, it's the same. This is not a statistically significant number, although the hazard ratio is a little bit higher. It wasn't a statistically significant for DVT for 10 milligrams either. For arterial thromboembolism, there was no question that they were all the same. There was no question they were all the same. And for deaths, deaths were 0.57 with TOFA 5, higher with 10, and a little bit lower with the TNFs. And again, this is not statistically significant. So when you look at this numerically, yes, in this study, there were numerically more events with tofacitinib, but the risk is relatively low still, and the number needed to harm is high. But tofa was not quite as safe as the TNFs. So let's talk about the VTEs first. So the VTEs, as I said before, most likely to occur in patients with RA compared to the general population. We know that. VTEs are more likely to occur in patients with moderate high RA activity. We know that as well. VTEs have occurred in all the clinical trial programs of the Jakinibs, including tofacitinib, baricitinib, upadacitinib, and actually some with filgotinib as well. And it's occurred with all of them, but it's also occurred with the comparators. And that's what I'm saying in this fourth bullet point. They also occur with placebo, conventional synthetics, and TNF. And for that reason, I'm going to make this very, very controversial statement. We do not know if one or more of the Jakinibs are more likely to produce VTEs than another. And I'm not sure that the JAKs actually produce more VTEs than other mechanisms of action. You see the numbers. I'm just not sure that we know all of the information yet. What I do know is that patients with rheumatoid arthritis, whether they're treated or untreated, are all at risk for a VTE, even though the rate may be small, and therefore you have to be very, very cognizant of that. So the important takeaway is that VTEs can occur in patients treated with any of these medications. You need to be aware of that. And you really have to think about patients who had prior VTE, post-surgery, oral contraceptives, etc., everything that raises the risk of VTE, and weigh the risks and benefits of individual patients. And that's very important. The conundrum that I have in practice is, if I see a patient who had a prior VTE, I'm going to be reluctant to treat them with a JAK. I am. But I'm also going to be reluctant to treat them with a biologic. And I'm also going to be reluctant to treat them with a conventional synthetic. And if I don't treat them with any of those, then their risk is even higher. So what do I do? And that's got to be a discussion with the patient in terms of what you decide to do. You can make an argument. I can use a JAK, the risk is low, I'll just watch out for things, maybe I'll prophylax, but I think if you prophylax, it can't be with aspirin because arterial events are not different. It's got to be with something that affects VTEs. Then you have the risk of the patient falling. So is that risk even higher? And it's a discussion with the patient. So you may decide you're going to take the risk and use a JAK, or you're going to take the risk and use a biologic, or you're not going to use anything other than a conventional synthetic, and then you can take the risk of the disease activity. But fortunately, the risk is low, but it's there. So based on 1133, those top-line results, there was a communication from the FDA. And what it said was, I haven't read, there's an increased risk of serious heart-related problems and cancer with the arthritis and ulcerative colitis medicine Xeljanz or tofacitinib. And then the second thing I haven't read is what they said was in February. So this is the beginning of February. So it's February, March, April, May, June, July. It's 6 months already. We will evaluate the clinical trial results we've received to date, and we'll work with the drug manufacturer to obtain further information as soon as possible. We'll communicate our final conclusions and recommendations when we've completed our review or have more information to share. And they haven't done it as of yet. So there are two possible reasons for that. One reason is like the rest of us, they were affected by COVID, and their work productivity probably was slowed down. And maybe they really haven't had enough manpower and enough time to really go through it. But more than likely, it's because it's so complicated looking at 1133. In 1133, it was a high-risk population. We didn't see it in the general population. We didn't see it in the clinical studies. Only in the high-risk population did we see that small increase. And how does the FDA convey that? Who are really the patients at risk? It wasn't everybody in that study. It was some. Who are the patients that are really at risk? And the other is there is no data with baricitinib, upadacitinib, filgotinib like this. They haven't done these studies. So is the FDA going to make this a class effect if they change the label, which my guess is they will, or will it be just for tofacitinib? And will it be for tofacitinib, then for the others, they'll say these risks, whatever they come up with, were seen with another Jakinib. We have to wait. So this is the boxed warning. This is the last PI U.S. Product insert from the FDA in February of 2021. So, and this is very interesting because it says thrombosis, including pulmonary embolism, DVT, arterial thrombosis have occurred in patients treated with Xeljanz and other JAKs, not just Xeljanz. Rheumatoid arthritis patients with at least one cardiovascular risk factor had a higher rate of all-cause mortality and thrombosis with Xeljanz 10 milligrams BID versus 5 BID or TNF. So in February, what they said was, be very careful with 10, don't worry about 5. We have to see how they're going to change that, if they're going to change that. Okay, now, I did this talk for EULAR, and I presented what I've just said before to EULAR, but last week the EMA came out with information, and I've included that here for you. So they actually went deeper into this, and they looked at MACE and myocardial infarction 1133. So here they take a look at MACE, and I've highlighted in yellow the incident rate of MACE, tofa 5 milligram BID, a little bit higher than TNF, that risk of 1.24. You saw that before. But then they broke it down to fatal MI. And actually, there were no fatal MIs with tofa 5 milligrams, but there was with the TNF inhibitors. This hazard ratio is 0, right? Because it were none with tofa 5. But with non-fatal MIs, the rates were very low, but it was double, right? So the risk of MI is not a fatal MI, but it's MI. So the EMA statement, and if you've seen this, this is online already, makes the following statement. The following predictive factors for development of MI, both fatal and non-fatal, were identified using this multivariate Cox model, a model with backward selection, and it was age greater than 65, not 50, 65. And if they were male, and if there were any history of smoking, these were the risk factors, and as well as the usual risk factors. A history of diabetes, a history of coronary artery disease, right, which you would expect. So in this study, which is enriched in order to look for these events, it was patients over the age of 65, smokers, diabetes, history of coronary artery disease. And they looked at malignancies, including non-melanoma skin cancers. And here I showed you this before. The risk was 1.13 versus 0.77 for a hazard ratio of 1.53. Lung cancer was the cancer that they saw. It was 0.23 versus 0.13. The hazard ratio is 1.84. A very low number, but still a little bit higher than the TNFs. And lymphoma was very, very low, it was 0.07 versus 0.02, because the risk of lymphoma was actually reduced in these populations. So their statement was, the following predictive factors of development of malignancies, excluding non-melanoma skin cancer, were using the model: age greater than 65, past or current smoking. I haven't seen the FDA analysis. I have seen some other data. I think that this is very reasonable. If a patient's over the age of 65 with a history of smoking, all right, because it's 65 and, that's the patient who's at risk. They also did serious infections, and they did the hazard ratio, and you can see it's really quite similar. So the risk of serious infections were further increased in patients over the age of 65. We know that. Any patient over the 65, whether they have RA treated or untreated, has a high risk of serious infection as compared to younger patients. I published this 20 years ago with multiple drugs. So here are the PRAC recommendations, which I'm sure will be accepted by the EMA. In the elderly, 2 points. No dose adjustments required in patients aged 65 years or older. Limited data in patients aged 75 years or older. It's very few patients in the study. But use in patients over 65 years of age, and this is an interesting statement. Considering the increased risk of serious infections, which is very minimal, myocardial infarction, and malignancies of tofacitinib in patients over 65, tofacitinib should be used only in these patients if no suitable treatment alternatives are available. So this is not saying don't use tofacitinib, but don't use it first and use it later. I think this goes a little bit further than the data. I think if they said over 65 with a history of smoking, then I would agree with that. But this is what their statement is, and this is what I think the EMA is going to do. What is the FDA going to do? I don't think the FDA is going to have a statement quite as draconian as this, but I think it will be similar. So these are the unanswered questions relating to oral surveillance. So what I showed you was the meta-analysis, registries, clinical trial programs didn't reveal a signal, because in those studies there were very few patients who were over 65 actually, and there were smokers, but not as many actually as in this program. But the study did suggest an increased risk of these safety signals versus TNF. It may be a small increase, but it was increased. And here the question's not been answered yet. So the first is, are the results of oral surveillance reproducible? I asked this question actually to the steering committee for this study, and said, of course it's going to be reproducible. We designed the study. But I've been involved in so many studies where you do a second study and it isn't reproducible. My guess is it would be, but I'd like to see it. And I'd also like to see head-to-head with the other JAKs. Are the risks observed lower with tofacitinib than an untreated or patient on conventional synthetic? That wasn't answered in this study. Patients were on tofa, 5 or 10, or TNF. They weren't just on conventional synthetics or no medications at all. They couldn't be. The study was 6 years in duration, and you couldn't continue many patients just on conventional synthetics because the disease activity would be too high. So we don't know that, but my guess is that the risks were lower with tofacitinib than an untreated patient, and they were lower than a patient on conventional synthetics. But that's just my guess. And are these risks just seen in this high-risk population? You have to wait for the data. But from what the EMA says, if the risk is greater than age 65 with a history of smoking, then a patient is 40 or 45 or 50 who hasn't smoked, the risk should be much lower. I think that you'll see that when you see the data. Does tofacitinib lower the risk but not quite as well as a TNF? And that's quite possible. So I think that that is what explains this study, that TNFs reduce the risk. They reduce the risk of MACE, and they do reduce the risk of malignancies like lymphoma by decreasing disease activity. And I think that tofacitinib does exactly the same, but maybe not quite as well as the TNF. Almost, but not quite as well. And then on the risk of these, if it's elevated, compared to other biologics, what about IL-6 inhibitors, costimulatory molecule, anti-B cell? They weren't tested. Is it the same or is it different? And then, are these increased risks just in patients with RA? This program is just in rheumatoid arthritis. It wasn't in PSA, it wasn't in AS, and it wasn't in inflammatory bowel disease. And those patients have different risk factors. They don't have an increased risk of VTEs. But PSA does have, patients are of higher weight, they have more diabetes, they have more lipid elevation, but is that population the same? And I haven't seen any of this data. What about adalimumab versus etanercept? Was there a difference between these two? Was etanercept better than adalimumab or vice versa, or the same? Should we be looking at the class of TNFs, or do we have to look at individual? And then really what's very important, is it just tofacitinib or is it other JAKs? And my guess would be that whatever you see with tofa, you're going to see with the other JAKs. But until you do the studies, you don't know. And especially a head-to-head study, which will never get done. And I doubt that studies will be done with the other drugs. They may, but they may not. And then very importantly is this last point. And that is, let's assume these results of oral surveillance are accurate. And there is a small increase in risk. There is. I've shown you that. Statistically significant because the upper bound of the hazard ratio is greater than 1.8. But would that change your risk-benefit assessment of tofa versus TNF and other biologics? So what I'm saying here is the number needed to harm is high. The benefits of the JAKs are good. There are patients who will benefit from JAK and not from a TNF. The fact that it's oral is better for many patients than something that's injectable. And if there's a small increase in risk, does the benefit outweigh that? That's up to you and the patient to decide. Okay, so what can we say? Who should not be treated with Jakinib? So patients with high risk of PE or VT, especially past history, really is a red flag. But as I said before, it's a red flag with all the drugs we use. But you have to think about it, and you have to discuss it with the patient. And then a high risk of MACE and malignancy, older age of smoking. I think that, to me, is going to be a driver. So if I see a patient who's 70 who has a history of smoking, I may use a JAK last. And then all the others are what you know about, because they're on the product inserts. But then the last slide is who could be treated with JAK preferentially. Well, a patient who prefers an oral medication rather than injectable medication for convenience or ease of administration, they just won't take an injectable. In my mind, benefit risk would be, yeah, use the oral. Or if a patient is intolerant and will not take methotrexate and other conventional synthetic DMARD, then the two mechanisms that work the best are JAKs or IL-6 inhibitor. Or if a patient that has sufficient response to multiple conventional synthetics or biologics, you've gone down the route, you've gone down the whole pathway, and you're not going to give them a JAK if they still have active disease with a small risk when they've failed everything else. You may decide to do that. I wouldn't. But whoever you do treat, you really do have to talk to them about the results of this study, especially if they're over the age of 65 with a history of smoking. So I'll tell you that in my practice, patients under 65, they don't have a history of smoking, and they failed methotrexate. I give them all the options, and I have no difficulty in my mind using a JAK before a biologic. Look at the results of this study. But if the patient's over 65 with a history of smoking, then my conversation with them is different, and I move JAKs further down the line. So with that, I'd like to thank you for listening. I hope this is of interest to you, and I'm ready for any questions.